Alright, so we've already talked about insomnia. Let's talk about problems with feeling too sleepy or sleeping for too long. There are a lot of information on these slides, but most of the conditions are very similar, and I'm not going to go over all the little details as much. Hypersomnia comes from hyper, which is Greek for over, above, or too much, and the Latin somnus for sleep. Hypersomnia indicates long sleep duration, excessive daytime sleepiness, or both. Hypersomnolence is the state of being excessively sleepy when a person should be alert. It's one of the most common sleep-related complaints that patients mention to their doctors. The International Classification of Sleep Disorders describes 8 central disorders of hypersomnolence. Although the ICSD-5 does not explicitly divide these 8 sleep disorders into 2 categories, we can discern 2 basic groups of hypersomnias. Primary hypersomnias, primary meaning the hypersomnia is not caused by another condition, and secondary hypersomnias, secondary meaning it's caused by or related to a different condition. Primary hypersomnias are comprised of narcolepsy, types 1 and 2 of narcolepsy, idiopathic hypersomnia, and recurrent hypersomnia with Klein-Levin syndrome or menstrual-related hypersomnia. Alternately, there are many disorders that can cause secondary hypersomnia. They aren't limited to just sleep disorders like obstructive sleep apnea or periodic limb movement disorder, but extend to other medical conditions, disorders, and diseases. For example, drugs, prescribed or not, and other substances will have side effects that can cause extreme sleepiness in those who take them. Hypersomnia is also noted in many psychiatric disorders. In addition, some people curtail their normal nocturnal sleep on a regular basis, resulting in inappropriate daytime sleepiness, and we call this insufficient sleep syndrome. EDS, or excessive daytime sleepiness, is the primary concern for many patients presenting with sleep complaints. EDS is a significant public health concern with prevalence in the community estimated to be anywhere from 4, 18, or 28%, depending on who you ask. Yet, because it is an invisible condition, hypersomnolence is linked to social stigmas, which often prevent patients from seeking help. Patients who are excessively sleepy are also greater risk for psychosocial problems, behavior disorders, motor vehicle and workplace accidents, and obesity. There are 4 cardinal symptoms of narcolepsy, commonly referred to as the narcoleptic tetrad. Tetra meaning 4, like Tetris is a game about shapes made of 4 blocks, which I just personally realized writing this presentation, trying to think of other words with the prefix tetra. It includes excessive daytime sleepiness, which is the most common feature of narcolepsy, cataplexy, which is sudden muscle weakness, hypnagogic and hypnopompic hallucinations, either visual, auditory, or tactile, and sleep paralysis, which is being physically immobile while conscious or awake. Cataplexy is dependent upon hypocretin levels. Cataplexy is reported in 20 to 50% of narcoleptics. Patients with cataplexy experience an inability to move their limbs or lift their head, or describe difficulty breathing. Sleep paralysis is often distressing because it may last up to a few minutes. It is usually interrupted by a noise or other stimuli. Low levels of neurotransmitter released by the hypothalamus, called hypocretin, also called orexin, contributes to the development of type 1 narcolepsy. Hypocretin helps the body regulate sleep. Approximately 90% of people with type 1 narcolepsy have low or undetectable hypocretin levels. Sometimes low levels of hypocretin may be related to an autoimmune process where the body's immune system mistakenly attacks nerve cells in the brain that produce hypocretin. Genetic factors are also involved in type 1 narcolepsy. If you've seen the fading goats online, you know that Sudden excitement can make them faint or fall asleep. And this is also true for some narcoleptics, but it can also be brought upon by something scary or really funny or super emotional. It's believed that because of the close proximity to the fight or flight or freeze center of the brain and the sleep control part of the brain, uh, like situation, fight or flight situation can cause sleep to occur. Specifically, it appears that it's REM sleep, which renders the body paralyzed. With narcolepsy, you get symptoms like EDS, sleep attacks, which is the sudden, irresistible urge to sleep, sleep paralysis, which is where a person wakes up but can't move any of their muscles, thought to be because they are still partially paralyzed from REM. And a lot of patients say that they feel like they can't breathe because there is a monster on their chest or the devil is sleeping on their chest. That used to be a big paranoid wives' tale. Sometimes people say they feel a presence in the room that wouldn't normally be there during sleep paralysis. Hallucinations can occur during wakening or falling asleep. To diagnose narcolepsy type 1, the patient must present with irresistible sleep attacks and either cataplexy or decreased hypocretin levels, and this must happen over a period of 3 months. Hypocretins are measured in the cerebrospinal fluid, collected via a lumbar puncture, which means a spinal tap. They take a needle and they stick it into your spinal cord and they get some of the clear fluid out. When testing for narcolepsy type 1, the cerebrospinal fluid concentration of hypocretin is either less than 110 picograms per milliliter or less than 1/3 of mean or average values of normal subjects. If you don't have the qualifying CSF concentration, you must have an NPSG and MSLT with at least 2 SOREMs, sleep onset REM periods. One can actually take place in the overnight NPSG. You must also have a sleep latency of less than or equal to 8 minutes and have cataplexy. This is for type 1 narcolepsy. Patients may qualify for narcolepsy type 2 if they do not have cataplexy, but they do have normal hypocretin levels. The symptoms are similar to type 1, but it doesn't have cataplexy. I'm not going to read through all this jargon. It's a lot of the same text, but I will explain what it says in my own terms. The main qualifying differences between type 1 and type 2 are the hypocretin level and the cataplexy element. Otherwise, if the patient can demonstrate 2 sleep onset REM periods in the combined NPSG overnight study and MSLT NAP study, that can warrant a diagnosis of narcolepsy type 2. Remember, a SOREM is when the patient achieves REM within the first 15 minutes of falling asleep. The additional criteria just covers that the symptoms are not due to anything like sleep apnea or medications. To render a diagnosis of narcolepsy, the provider must collect a complete sleep history from the patient and optimally from partners, relatives, and friends. The patient will be expected to take some sleepiness scales like the Epworth and the Stanford Sleepiness Scale, which we've talked about before. These are both subjective measures of sleepiness. The Epworth measures tendency to fall asleep during certain scenarios, and the Stanford sleepiness scale is based on how sleepy a patient is right when they're taking that test. An NPSG is usually necessary before an MSLT to make sure the patient can sleep 6 hours with any other causes of excessive daytime sleepiness like sleep apnea or arousing limb movements. The MSLT is comprised of 5 20-minute nap opportunities where the patient tries to fall asleep. If they do fall asleep, the study is then extended an extra 15 minutes to see if the patient starts to dream. In the MSLT, a sleep onset REM period, or SOREM, is defined as a REM period during the first 15 minutes following sleep onset. A mean sleep latency of less than 5 minutes is indicative of a significant EDS, when longer than 10 minutes is considered within normal levels of alertness. Approximately 90% of narcoleptics have a mean sleep latency of 8 minutes or less. However, SOREMs remain a more specific predictor of narcolepsy than the sleep latency. HLA human leukocyte antigen DR2 DRB1 asterisk 1501 and now DQB1 asterisk 0602 genes are thought to be the reasons for narcolepsy and was originally thought to be an immune disorder. 90% of narcoleptic patients have the 0602 gene. Treatment for narcolepsy varies from person to person, and there is no cure, so the only thing left to do is to control and improve the cataplexy and EDS. This is possible through medication and even short naps. The treatment for narcolepsy is very similar to the treatment of idiopathic hypersomnia, but short naps only seem to work for narcoleptics and not the idiopathic hypersomniacs. Notice on this table the second line antidepressants are notorious for being REM suppressants, so it makes sense to try and inhibit the REM interruption during overnight sleep. These are all treatments for excessive daytime sleepiness. The first line medications include modafinil and armodafinil. Second line treatments include different types of amphetamines and stimulants of varying release, like extended release or immediate release. You may see different names like Nuvigil or Provigil for the first liners and then Ritalin and Adderall for the second liners. If you're ever unsure about what a medication is or if it has a different name, just use your Google machine. To help cataplexy, hallucinations, and sleep paralysis, the top line drug is Xyrem, or sodium oxybate. This is heavy-duty stuff. You can't go to a pharmacy and get it. It has to be hand-delivered to you at your house. When you take Xyrem, you have to be in bed and have the dose on the side table stand because after you take it, you might have about 2 or 3 minutes before you're gone. I've had a couple patients on Xyrem, and this was true for both of them. A lot of them have 2 doses so that when they have one and then another halfway through the night. But now there are single-dose Xyrem treatments as well. Pitolisant is also called Wakix and is a histamine inverse agonist. If you know anything about histamine, an antihistamine can make you sleepy. Mazandal, also called Sanarex, is a tricyclic non-amphetamine stimulant. A non-amphetamine stimulant is something that keeps you awake without meth, basically. There aren't many mechanisms shown to be as effective as meth, but it's obviously got terrible side effects, and it's easy to abuse. Just watch Breaking Bad. Like the name suggests, we're idiots and we have no idea why you have hypersomnia, therefore we call it idiopathic hypersomnia. It's very similar to narcolepsy type 2 in that it doesn't require SOREMs or cataplexy, but it does show high sleep efficiency on the PSG and long sleep periods with resulting sleep inertia. Naps don't help idiopathic hypersomnia, but they do help narcoleptics. If the idiopathic hypersomniac is thought to be caused by medication, they will probably trial a period of time without that medication. Drug tests are frequently a necessity for an MSLT integrity. IH can also be treated with drugs. The newer version of the ICSD is supposed to break down idiopathic hypersomnia into 3 subgroups. Subgroup 1 is defined as idiopathic hypersomnia with a positive family history. Associated clinical symptoms suggest dysfunction of the autonomic nervous system. Symptoms may include headache, syncope, which is fainting, orthostatic hypotension, and peripheral vasoconstriction, like cold hands or feet. Subgroup 2 is categorized as an initial viral infection associated with neurologic symptoms like Guillain-Barré syndrome, infectious mononucleosis, or atypical viral pneumonia. Even after their infectious disease resolves, these patients continue to require significantly more total sleep and continue to feel very tired and sleepy in the day, often napping. An analysis of the cerebrospinal fluid demonstrates moderate lymphocytosis, or 30 to 50 cells per microliter with mild to moderate elevation in protein. Subgroup 3 suggests that some patients do not have a positive family or viral infection history, making the cause of this disorder truly idiopathic. To what extent these subgroups will define the future of idiopathic hypersomnia is unknown and in need of more further validation. The diagnostic criteria to diagnose idiopathic hypersomnia is very similar to narcolepsy, but there are no SOREMs or cataplexy. The patient has to be able to demonstrate sleep initiation with a mean sleep latency of 8 minutes over 5 naps during an MSLT, or the patient has to have a 24-hour PSG which shows they sleep about 12 hours, or have a wrist actigraphy study with a sleep log. The physician has to be careful with these things to make sure the physician isn't inducing sleep deprivation with insufficient sleep syndrome at home. Recurrent primary hypersomnia is an episodic, meaning it comes and goes, long sleep disorder where a patient shows symptoms of EDS and long sleep duration for some time between 2 days and 5 weeks. There have to be at least 2 of these occurrences. Typically, these episodes happen more than once a year and at least twice every year and a half. In between these episodes, they have normal functionality, behavior, and alertness. During these episodes, the patient must also complain of at least one of these symptoms: cognitive dysfunction, or brain fog, can't really think very well; altered perception, where reality looks different; an eating disorder, either anorexia or hyperphagia; and disinhibited behavior like hypersexuality. You just don't care anymore. Like the others, in order to qualify for recurrent primary hypersomnia, the symptoms can't be explained by any other reason. Klein-Levin syndrome, also known as sleeping beauty syndrome, or when patients have episodic or recurring cycles of severe hypersomnia and associated problems with cognitive elements like memory and language, psychiatric elements, mood, delusions, and hallucinations, and behavioral, like hyperphagia and hypersexual. Every cycle ends and disappears, and eventually will just totally go into remission, almost like growing out of it. It's considered cured if there haven't been any episodes for more than 6 years. A little history on Klein-Levin syndrome. Multiple cases of recurrent hypersomnia were first collected and reported in Germany by Willy Klein. Max Levin emphasized the association of periodic somnolence with morbid hunger in 1929 and 1936. Critchley was the first to name this sleep disorder, and by 1962 Critchley had developed the fundamental features that we recognize as KLS today. He described a triad of symptoms, highlighting periodic hypersomnia, excessive and compulsive eating, and abnormal behavior. He also noted that young adolescent males were predominantly affected, and that the syndrome will spontaneously disappear. Briefly interjecting with menstrual-related hypersomnia here. Right now it's considered a variant of Klein-Levin syndrome, obviously for females. This can happen a few days before a cycle begins, and it's assumed that the symptoms are from hormonal changes. Because of this, providers may elect a trial of estrogen and progesterone therapy to elicit a positive response. In this case, it may mean a reproductive or endocrine abnormality. Klein-Levin syndrome is very rare. 42% of KLS patients say they had illnesses 3 to 5 days before the first episode. This sounds like KLS has a trigger or stressor that activates its symptoms. 9% of patients feel sick before each cycle happens. Episodes may happen as many as a few times per year, and they could last an average of about 10 days. Compared to men, women experience longer symptom duration. The other proposed causes of KLS are hypothalamic dysfunction, because the hypothalamic and the third ventricle tumors have symptoms similar to those of KLS, or a neurotransmitter imbalance, because some abnormalities in serotonin and dopamine metabolism have been reported in these cases. If you haven't already noticed, KLS has some very specific symptomology. Of course, there's hypersomnia. There's also a lot of mental or cognitive problems that can range from abnormal speech, confusion, amnesia, derealization, hallucinations, delusions, depression, and irritability. There's also a marked change in appetite, either hyperphagic or excessive eating, or hypophagic or anorexic. They are also disinhibited, or they don't feel shame or guilt, and they may exhibit hypersexuality or compulsions trying to sign or write or pace. Patients may suffer from hypersomnia secondary to a medical disorder. In order to qualify, all the criteria has to be met. For at least 3 months, the patient must have daily periods of irrepressible need to sleep because of a significant underlying medical or neurologic condition. If an MSLT is run, the average time it takes to fall asleep should be less than or equal to 8 minutes and no more than one SOREM. If there are two SOREMs, the patient most likely qualifies for a narcolepsy 1 or 2 type due to a medical condition. That's a thing. If this hypersomnia is due to obstructive sleep apnea and CPAP treatment follows, the MSLT means sleep latency may be more than 8 minutes. It's totally possible. I've run patients with CPAP and they still have narcolepsy. If there are patients with severe neurologic or medical disorders and it is not possible or desirable to perform sleep studies on them, the diagnosis can be made just based on clinical criteria. Along with EDS, other features of narcolepsy may be present, such as sleep paralysis, hypnagogic hallucinations, or automatic behaviors. But if the patient also has cataplexy or the MSLT shows 2 or more SOREMs, or the CSF hypocretin 1 levels are low, then narcolepsy type 1 or 2 due to medical conditions should be diagnosed. Parkinson's disease and medications to treat Parkinson's disease have been shown to cause hypersomnia, levodopa or L-dopa being the prominent Parkinsonian drug. People may also experience long sleep time because of post-traumatic stress disorder. Genetic disorders that deal with the primary nervous system and brain tumors, infections, and lesions all can be a cause of hypersomnia. Medications are huge when it comes to being stimulated or put to sleep. Mixing drugs is also dangerous because even if they separately work well for a patient, the interaction between the two could amplify or decrease the efficacy or even cause other problems. The reason most of the celebrities are dying nowadays are because they are mixing alcohol with other drugs like narcotics, and the mix of the two is enough to suppress their respiratory drive, and they just have central apneas until they don't wake up anymore. In order for a patient to qualify for a diagnosis of hypersomnia secondary to medication, the patient must have daily periods of irrepressible need to sleep or daytime lapses into sleep. Their daytime sleepiness happens because of the current medications or substances they use, or even the withdrawal from sleep or from wake-promoting agents. For hypersomnia to be truly caused by only medication, other sleep, medical, and mental and neurologic disorders must be ruled out. Hypersomnia secondary to medication could be from an intentionally sedated medication like Xyrem or Ambien, or an unintentionally sedating medication like Benadryl, where sedation is a side effect, or hypersomnia can occur from substance abuse. Hypersomnia can also occur in patients that are coming off stimulants like Adderall or Ritalin. You might be asking why we have these certain designations and why we don't just say they have hypersomnia. The providers have to really be specific on what kind of hypersomnia the patient has for medical charting purposes. A diagnosis of hypersomnia due to medication does not automatically qualify a patient for another treatment or medication, but provides a label or a diagnostics for the symptom that is severe enough to have its own designation. Sometimes, in order to qualify for a different or better medication, primary meds have to be started first, and then, citing problems, they can be changed. Hypersomnia may also manifest as an effect of a psychiatric disorder. In order to qualify for a diagnosis of hypersomnia due to psychiatric disorder, 3 items must be met. As with all hypersomnias, the patient must experience daily periods of irrepressible need to sleep or experience daytime lapses into sleep occurring over a period of at least 3 months. The sleepiness must occur in association with a concurrent psychiatric disorder and must not be better explained by another sleep disorder or medical condition or neurologic condition. Here are a couple psychiatric disorders that are correlated with hypersomnia. Seasonal affective disorder and bipolar affective disorder patients are both apt to hypersomniac conditions. SAD patients during the fall and winter months, and bipolar during the depressive phase. It could also be associated with conversion disorder or a somatic symptom disorder. Conversion disorder is quite an interesting one because the patient spontaneously loses ability to do things, like they go blind or paralyzed, or they lose other senses of consciousness which can't can't be explained. Patients may also experience hypersomnolence due to insufficient sleep syndrome, and the name speaks for itself. The patient has daily periods of irrepressible need to sleep, or daytime lapses into sleep, or there are complaints of a person falling asleep inappropriately. After collecting sleep logs, diaries, and actigraphy, the sleep time is usually shorter than expected. This must have been occurring for at least 3 months. The patient's sleep is usually cut short due to an alarm clock or another environmental aspect in the patient's room, and the patient would normally sleep longer during the weekends or instances where they did not have to get up early. If the patient is able to sleep longer and symptoms resolve, that's another sign that they also suffer from insufficient sleep. Also, it can't be explained by any other better reason. For insufficient sleep syndrome, it's the patient's schedule or own deliberate sleep deprivation that is causing the hypersomnolence. People who work too much or have odd hours, students who push too hard, certain social obligations or personal choices can shape the sleep architecture into a stunted form of what the patient really needs. These treatments for insufficient sleep syndrome is sleep hygiene education and behavior adjustments. For people who party, study, or work all night, they must have a time for a hard stop so that they can ensure enough sleep time to stave off hypersomnolence. Hygiene also includes not consuming caffeine too close to bedtime, not napping after 2 p.m. or at all if possible, staying away from blue light or screens just before bedtime, and other things like that can help the ISS sufferer transition back into better sleep. Finally, we have long sleepers. Long sleepers are people who just need more sleep than the average. Typically, they sleep 10 to 12 hours a night. They tend to go to bed earlier and wake up later than the average sleeper. Insufficient sleep syndrome is often common with long sleepers. Speaking of long things, this was a long part B, so take a break and look at something into the distance to fix your eyes from looking at this screen for too long. All right, study hard.